All right, well, welcome everyone. The Affordable Care Act, AKA the ACA, turns 12 years old this year. And since 2010, we've seen the implementation of Medicaid expansion, subsidized private health insurance in the ACA marketplace, and most recently, the expansion of those subsidies under the American Rescue Plan Act, ARPA, of 2021, among many other provisions. Today, we turn our attention to how the ACA has benefited the Asian American, Native Hawaiian, and Pacific Islander communities, what is at stake with the looming expiration of ARPA, and the coverage gap still remaining. Welcome again. My name is Brandon Yan. I'm the Director of Health Policy for the Asian Pacific American Medical Students Association, otherwise known as APAMSA, and a MD-MPH candidate at UCSF Harvard. Here with us to discuss the ACA and more is Dr. Howard Koh. He's the former Assistant Secretary of Health in the Obama administration, former Massachusetts Public Health Commissioner, and current Professor of Public Health at Harvard. Dr. Koh, welcome, and thanks so much for joining us.
Thanks so much, Brandon. Great to be here.
Let's start by going back to the pre-ACA years. Can you remind us of what the healthcare landscape in the US looked like before the ACA and the key gaps that existed during that time?
Sure, Brandon. And before I begin, I just want to thank you for organizing this event. And I want to congratulate APAMSA and your president, Donna Tran, for leading this wonderful organization. You know, when I was a medical student back in the day, there was no organization like APAMSA to encourage the next generation of leaders, no role models. And so many may know that I have now been first the Massachusetts Commissioner of Public Health and then later Assistant Secretary for Health in the Obama administration. In both roles, I was the first Asian American in those posts. And so I've been very supportive of any efforts that highlight the importance of AANHPI health. So this is a very important webinar today. So thank you for inviting me. And then back to your question, I started at Health and Human Services in the Obama administration in 2009. You may remember that was when the last pandemic occurred, the H1N1 pandemic. And then just as that was quieting down, on March 23rd, 2010, the Affordable Care Act was signed into law. So as you noted, Brandon, we just celebrated the 12th anniversary last week. So that law was so important because everybody, regardless of your point of view, agrees with the following, that the US has the most expensive healthcare system in the world without the outcomes to match. And in fact, we don't really have a healthcare system. It's fragmented, it's a patchwork. We have private insurance, we have public insurance like Medicaid and Medicare. Very importantly, back then, close to 50 million people were uninsured. I think the exact number was 47 or 48 million. There was discrimination back then against those with pre-existing conditions. So if you had a serious illness and got sick, often that prevented you from getting any insurance in the first place. You know, young people would have to get off insurance and have a gap before they could get on to their own plans. And there were terrible disparities in terms of health insurance coverage. So those are just some of the issues back then, Brandon. And then from my point of view as a public health professional, there was just not enough attention to prevention, coverage of preventive services like cancer screening. So my job as the Assistant Secretary for Health was to focus on ACA and public health and prevention. In fact, all of us at HHS, all 80,000 of us were there supporting then Secretary Kathleen Sebelius, but trying to make sure that this helped all people in the United States, regardless of background, but particularly have outreach to communities of color. So that's my point of view back then when I started my job in 2009, and then particularly 2010 when the ACA was signed into law.
Yeah, and since the ACA has passed, we've seen these huge gains in healthcare coverage. The uninsured rate for non-elderly adults has dropped from about 18% to 11% nationally. I want to talk next about a paper that you co-authored in JAMA Internal Medicine on the gains in healthcare coverage, specifically the Asian American, Native Hawaiian, and Pacific Islander communities. So Dr. Koh, can you share with us some of your key findings here and what they mean for this community?
Sure, Brandon. That's a great story. So I hope you don't mind if I spend some extra minutes just describing the evolution, because it's a great story to tell, especially this audience. So when the ACA was signed into law 12 years ago, and we were trying to reach everybody, particularly communities of color, the unspoken assumption back then was that it was going to be too hard to reach the AANHPI community because we are so heterogeneous, as we all know. We represent so many different cultures, over 50 ethnicities, over 100 languages. But we are the fastest rising minority group in the country. And so it's very important to reach as many people as possible with the promise of health insurance coverage through the ACA. So I worked hard on that both internally within government, within the Obama administration, and very importantly, externally with some really truly inspiring advocates around the country who were really passionate about making sure that the AANHPI community had education and outreach and understood their options in getting life-saving insurance. I met with these groups regularly during the time I was assistant secretary, and they always inspired me because they were working as navigators and assisters and doing outreach in different languages and enrolling people into marketplace plans and Medicaid. And then very importantly, there was a national advocacy umbrella organization called Action for Health Justice. Many of you may have heard of it. I think there was something like 50, 60 organizations involved in that. Two I want to mention are the Asian Pacific Islander American Health Forum in California. At the time, that was led by my dear friend Kathy Ko Chin. Now is led by my dear friend Julia Choi. And then another one that I want to mention in particular, the Association of Asian Pacific Community Health Organizations, or APCHO. Those are the community health organizations, community health centers that focus on AANHPI populations. That's headed by my dear friend Jeff Caballero. So I worked very closely with all these colleagues. And so we were proud to say that the AANHPI community was not overlooked here, and there was a lot of outreach. And then 12 years later, last week, we've been able to celebrate a lot of success. The uninsured rate has dropped almost in half. And then health disparities have narrowed tremendously with respect to gaps between blacks and whites and Hispanic Americans and whites. So we're all proud of that. And then I left DC and returned to Harvard and continued to follow all this. So this is when the story begins. About 5 years ago, here I am a Harvard professor. This is about 2017. One of my Harvard public health students, like you, Brandon, and by the way, Brandon, you've done very nice work in contributing to the literature. So thank you so much for your contributions. But one of my Harvard public health students back then, John Park, was serving as my research assistant and tracking the AANHPI health literature. And one day he met with me and said, Dr. Ko, I've been looking at the literature and there is no published analysis on whether the ACA improved health insurance coverage for the AANHPI community. And I said, what? Are you sure? Somebody must have done that. I mean, we've done that for other communities of color and, we think disparities are narrowing. So I double checked and of course he was right. There had been one letter that was published, but it was not a formal, detailed analysis. So John and I decided to do something about this. And so the very first thing I did, which I was very proud to do, was organize a top-notch research team to work together on this with John as the lead. And by the way, it's very important to mention to this largely student audience today that, oftentimes students say, oh, what can I do to contribute? And, I don't have the experience, but John was so motivated that he had to be the lead author. He did most of the work, for goodness sake. And what I did was build the best research team possible to support him. So the team worked together for over a year, and I just want to single out our co-authors because they're all highly recognized and respected health policy researchers. Drs. Arnie Epstein, Graham Kolditz, very importantly, Dr. Ben Summers, who's back at HHS now in the Biden administration, Sarah Humble, a research analyst at Washington University. And in 2018 and 2019, we had 3 publications on AANHPI health insurance coverage after the ACA. They were in JAMA Internal Medicine, as you noted, Brandon, but also in Health Affairs and also in the Academy of Medicine blog. So here's the bottom line. Before the ACA, there was a gap in coverage. The AANHPI uninsured rate was about 19%, and for whites it was about 15%. But then post-ACA, according to our analysis, both the AANHPI groups and the white populations had about the same uninsurance rate, about 9%. So that's what you're showing in your table right here, Brandon. So, I'm sure the whole network in APAMSA is very aware that it's really important to tackle health disparities and very hard to eliminate disparities. But for this moment, and for these analyses, we showed that the gap was basically eliminated. And that was pretty astonishing. Now, one caveat I have is that our analysis stopped in 2016. And maybe others on the call know whether there have been more detailed analyses since then. But I thought that was a moment to pause and reflect. And obviously, everyone's going to say, first of all, has the progress continued up till now? I sure hope so. We got to update this analysis. Maybe some folks in the audience can do that. But the bigger question is, why did this happen? And of course, we can't prove causation. But I am pretty sure it's because of the incredible dedication of advocates around the country from coast to coast who decided that we have to support our community. We have to do it in a culturally sensitive way. We have to do it in multiple languages, be sensitive to people with low incomes, of course, and that's the result. So to this day, Brandon, we're very, very proud of this. And in fact, yesterday I had the pleasure of being on an ACA webinar with Nancy N. DeParle and Marilyn Tavener, who were two of the highest leaders in the ACA in the Obama administration. And this analysis came up, and I was very proud to review that outcome for that audience. So in short, we can eliminate disparities, we can support the AAA and HPI population, and it's very important to have the data and facts to back that up.
Thank you, Dr. Coe. It's certainly a really remarkable piece of research here that you and your team have done, and really remarkable findings that we're seeing in terms of the benefits of the ACA. Now, I want to talk, another major strength of your paper was the use of disaggregated data across Asian American and particularly Pacific Islander subgroups. Can you walk us through why you decided to show disaggregated data and why that's really important for research moving forward?
Well, that's a great question, Brandon. And let me get very personal on this. Back when I was a medical student, I said, okay, when I get my MD, I'd like to help the Asian American community, now the AANHPI community. And I looked in the literature and there's literally next to nothing. I mean, that was a number of years ago, of course. But time and again, I'd look in the literature and there was nothing on AANHPI health. In fact, among the few of us who were committed to this back then, there was a joke that there's an acronym, TIALOD. There is a lack of data. I mean, time and time again, we would hear that. And there are all these excuses. Okay, well, your population's too small, you're too heterogeneous, but our population kept growing. And in the meantime, when I was looking for data relevant to AANHPI health, and particularly to Korean American health, I'm from a Korean American immigrant family, we'd always be lumped into the other category. I mean, that really got kind of old, right? So fast forward to today, the AANHPI population is 7% of the US, but there was a very important study a couple of years ago documenting that NIH devotes only 0.17% of their budget to studying the AANHPI population. So that's been a source of great frustration for too long. And you may start to say, okay, well, data, that's kind of dull stuff, and I want to talk about something more interesting. But if there's no data, too many people conclude there's no problem, and then you can't tailor programs to address the issues that affect our community the way they affect every other community. And then one issue about data is that when you get AANHPI data, it's often aggregated, and then people make all kinds of extrapolations about our various subgroups. The data can be inadequate. And so when the ACA came along, it improved data collection, and there was this obscure section of the ACA, section 4302, that I was very interested in as the Assistant Secretary, and it required that for all self-administered federal health surveys that the AANHPI respondents could also check off whether they were part of a major Asian American subgroup like Asian, Indian, Chinese, Filipino, Vietnamese, Korean, and Japanese. Each of those 6 have populations over 1 million in the US, by the way, or improvements in at least 3 major Native Hawaiian and Pacific Islander subgroups, Native Hawaiian, Samoan, or Guamanian, or Chamorro. So what you're showing there, and what we also published in Health Affairs and in Academy of Health, Brandon, is that we broke this down by these major Asian American and NHPI subgroups. And I'm proud to report that in all the populations, the subpopulations, that there was improvement. For the NHPI subpopulations, I'm not sure we could assign significance because the numbers were too small, but the trends were all going the right way. So let me give you the example that spoke most personally to me. I was always concerned as a Korean American that Korean Americans have the highest uninsured rate of any AANHPI subgroup. Pre-ACA, that was close to 30%, as I recall. I'm not sure we've ever figured out exactly why. Korean Americans have high numbers of small business owners. A number of my uncles ran small businesses, for example, in dry cleaning and in groceries, and I was never sure if they had health insurance. Post-ACA, that number dropped down to 13%. So that's pretty dramatic, and we're very proud of that. So I'm hoping, Brandon and colleagues, that as we do more of this going forward, we can have more detailed data, more accurate data, and break it down in a disaggregated fashion as much as possible. And if we can do that, we can bring much more needed attention to public health issues for our community.
Yeah, thank you, Dr. Koh. And I really want to highlight what you said about the importance of data here, because when there isn't data, there is that assumption of maybe there isn't a problem here, or people aren't paying attention. And we certainly saw that happening with COVID and the lack of data on the AANHPI community and the COVID's impact, especially early in the pandemic.
Yeah, Brandon, I appreciate the article you wrote, working with my good friend, Dr. Tung Nguyen from UC San Francisco. So congratulations. That was a very important contribution. Again, through COVID, I was looking for AA and HPI data, hard to find. And then you and Dr. Nguyen and colleagues wrote that up. And so that was a very nice contribution. So thank you for that.
Appreciate that. It's very kind of you to say. I want to switch gears a little bit now and talk about one of the key debates on Capitol Hill, and that is the looming expiration of ARPA subsidies at the end of the year. And for those unfamiliar, the American Rescue Plan Act was passed in 2021 for COVID relief. Now, one provision was the expansion of the subsidies to purchase private health insurance on the ACA marketplace. And in short, I won't go into the great details, more people got financial help and the help was larger. But this provision will expire at the end of this year. Now, Build Back Better would have extended these, but has now famously stalled. Dr. Koh, can you talk a little bit about how concerned you are about the loss of ARPA subsidies and what it means for Americans?
Sure, Brandon. And of course, let me just back it up by saying that when you get into public health, the reality is that there's always going to be debates and disagreement and political struggles about any public health proposal. And so just getting used to debates and controversy is just what this field is all about. And if you want to make progress, you got to commit to the mission of what you're trying to do and persevere and be in it for a long time. So, for example, if you look at the history of the ACA, so let me start broadly before I answer your specific question, Brandon. We can say a dozen years after signage that there have been, almost 70 efforts to repeal and replace the ACA. There have been multiple lawsuits, including 3 that went up to the Supreme Court. The first one was decided by 1 vote to uphold the ACA, and that first decision made Medicaid expansion optional, as you all probably know. The third decision was last summer, and when that upheld the ACA yet again, most public health experts said, okay, we think that might be it. And everybody may decide to move on and try to make this work and not try to repeal and replace it. And then thank God, Medicaid expansion and marketplaces existed through the ACA because COVID hit. Can you imagine what the healthcare landscape would look like if we didn't have millions more with insurance coverage after COVID hit in January 2020. So that's all background. But with respect to your specific question, as you were showing here, we had support from Congress for the American Rescue Plan to a lower monthly premiums on the marketplace with support from premium tax credits. So that's good news, and it helped people get insurance they need and deserve. I mean, you need much more than insurance to be healthy, of course, but it's hard to be healthy without insurance as a very necessary part of this. And so, we've had more support politically for the ACA, great progress, as you've already mentioned, Brandon. And now, as you've noted, there's a major concern that the funding for these premium tax credits will end at the close of 2022. And there have been estimates now from HHS that an estimated 3 million people might lose insurance if those tax credits lapse. So we just cannot allow that to happen. And in fact, right now is a very important time to talk about the future of health insurance coverage and public health. I mean, everyone's so tired of COVID, they want to think about something else and move on, but we can't do that. We have to use this quieter time. It's never going to be quiet, but it's quieter, to rebuild public health, make health insurance coverage as strong as possible, because the next threat is coming sooner rather than later, and we just cannot go through what we've been through the last number of years.
And certainly a call to action there, exacerbated by the COVID pandemic. I wanted to ask in follow-up then, what are the barriers that you see preventing Congress from being able to extend these ARPA subsidies or to make progress in this area? The political, economic, social, or something else in nature?
Well, unfortunately, it's all the above, I think. And here's one thing that's a struggle already. You would hope that after what our nation has gone through, that we would have as much funding as possible to rebuild health systems and public health and pandemic response, for example. But in the budget negotiations that ended just recently, Congress decided that we couldn't afford, I think the number is $22 billion for pandemic relief and rebuilding health and public health systems. I think, again, if you step back, the way our country has been devastated for the last 2 years, I mean, why is that funding optional? We have to invest not just for the health outcomes, but for businesses and schools and for having society function at all. I mean, that's a good use of funding. So I'm hoping our budget officials and our congressional leaders in particular will lean into making that relief a reality sooner rather than later. And that includes the premium tax credits that we're talking about here. Otherwise, more people will lose insurance. Our health outcomes will continue to get worse, and we're not going to be ready when the next threat comes. And we just have to be much more proactive about healthcare, health insurance, and public health than we've been in the past.
Thanks, Dr. Ko. Let's stop my share here and move to our next question. Slightly different topic, but things that we've talked a little bit about, touched upon already. Thinking longer term, 30 million Americans remain uninsured. And as you mentioned, more if ARPA subsidies expire. Now, equity, of course, is a key concern. It's about 7% of ANHPIs remain uninsured, and we acknowledge these rates are as high as 20 to 22% in the Hispanic and Native American populations, according to data from the Kaiser Family Foundation. Thinking public policy-wise, what policy options do we have to advance equity and bring universal coverage?
Okay, what a critical question. And again, let me get personal first before I directly address your question nationally. So Brandon, you and I are in Boston right now in Massachusetts. I'm the former state health commissioner here. And so I know and love this state. And many of you may remember that in 2006, Massachusetts was the first state to have health reform based on the same principles that the ACA was built on starting in 2010, individual mandate and Medicaid expansion and marketplaces, et cetera. And so I lived through that in 2006. At the time we had a Republican governor and a Democratic legislature. None of this is easy, but it passed and it got implemented. And 16 years later, it's very well accepted in our state. And our state has one of the lowest rates of uninsured in the country, about 2.5%, from what I can remember. And the disparities narrowed considerably. So it would be great if the nation had a similar trend. And I've reviewed all the controversies and lawsuits and disagreements, but I'm hoping that's going to quiet down. We still have 12 states, a dozen states that still have not expanded Medicaid, most notably Florida and Texas. And there are lots of vulnerable people caught in the middle of that, particularly people of AANHPI and low income background. And so, we need to keep pushing on this as hard as possible and not let people forget that we can't stop until everybody gets the coverage they need and deserve. Of course, leading up to the 2020 election on the Democratic side, there's a lot of discussion about single payer, and that was a issue where many debated. And then COVID hit, and now we have lots of international crises, of course, and we're not hearing much about that anymore. And so I think objectively, the odds of that issue coming back on the agenda for the nation is probably low. So I think we got to focus on what we can do here and keep pushing where we are, particularly focusing on those 12 states that still have not expanded Medicaid. And I hope if we do, we can get to a better place sooner rather than later.
Thank you for your insights, Dr. Ko. It's clear that the ACA has dramatically improved healthcare coverage for Americans, including, as you mentioned, cutting the AANHPI uninsured rate about in half. We still got a long way to go. Medicaid expansion, not expanded in 12 states. So a long way to go before we get to universal coverage, and hence why continued policy advocacy is so important. I want to thank you. This concludes the first part of our webinar, but I want to move into our second part. Before we move into Q&A, I want to thank a few people who helps make this happen. So Donna Tran is President Donna Tran of APAMSA, Vice President of Advocacy Daniel Pham of APAMSA, Sydney McClendon from the Harvard Chancellor, who was a wonderful classmate of mine, and the entire APAMSA communications team. Today's event would not have been possible without all of you. And to keep in touch with APAMSA, we are on Twitter, Instagram, and Facebook, and the speakers today are also on Twitter. Our handles are Dr. Howard Ko, and for myself, BN415. And with that, we're going to move into a time for a Q&A session. The audience members have submitted questions either through the registration form or in the Q&A box today, and we have a few questions that we want to ask in the remaining 15 minutes. Okay, so let's see. Dr. Ko, all right. How can AANHPIs balance taking and giving space in advocacy as both a minority group facing discrimination and a group that enjoys particular advantages as well?
Yeah, so this is quite a time for the AANHPI community, Brandon, and everyone, for obvious reasons. We're all so concerned by what COVID did to fuel xenophobia against our community. And those ramifications are really severe, and I'm concerned about it having lasting effects on our community and our country. You all know that it was about a year ago, actually, for example, that there was that shooting in Atlanta of 8 Americans, including 6 of Asian descent. So as one who's been at this for a long, long time, the silver lining is there's more interest in AANHPI health and public health than ever before. Congress had their first hearings on anti-Asian hate last year. Many of those leaders, particularly Congresswoman Judy Chu, are leaders that I had the pleasure of working with when I was in DC. I respect her so much. The president signed a COVID-19 Hate Crimes Act into law. A lot of these issues affect students and ironically affect students and doctors and nurses and health professionals of AANHPI background who are trying to care for people with COVID. And meanwhile, they're just as vulnerable to attack on the street as anybody else. So this is a time where I think every member of our community and every student can at least make everybody else aware that we have to reverse the discrimination and xenophobia. And we can do it where we study and work. I mean, AANHPI issues should be part of every diversity, equity, inclusion effort anywhere. In medical schools in particular, Dr. Karen Kim of University of Chicago, a dear friend, and Dr. Holly Humphrey, who's now at the Macy Foundation, and I just co-wrote a piece about the need for more education in medical schools about AANHPI issues. You know, when we interact with patients of AANHPI background, maybe we can even signal that we understand that there's a time of real stress for our community. And I think taking that extra step of reaching out right now is something that all of us can do, regardless of our background, regardless of whether we run big organizations or not, or if we're just a student, for example. I think this is a time to make everybody else aware in the country that this is a critical time for the health of our community and for the country going forward.
Absolutely, with the anti-Asian hate that's been happening the last few years, really important to bring about that awareness and action following. Another question that we're seeing that we have in the chat here, it looks like, is to you, Dr. Ko. How did you find your purpose? And how do you deal with imposter syndrome?
Okay, that's a great question. So, Brandon, when you get to my stage of the game, I get to spend a good part of my week advising students and mentoring students. It's always a great honor. And to have young people committed to healthcare and public health right now is really important, especially from the AANHPI community. And as one who's had my share of mentors going through academic medicine and going through training and everything, I've had too many mentors say, okay, you have to do this and you should never do that. And they tell you their opinion. But when I meet with students, I often ask them, okay, what are your interests? But then, what do you think your mission is? Or do you feel like you have a calling of some kind? Or what do you find yourself drawn to where you think you want to make a difference? And Brandon, when I was a medical student, I never thought I'd be in public health. I never thought I'd be in government. I didn't know what public health was. I was too interested in passing my next exam and trying to be the smartest guy around. But I learned very early on as a house officer, as an intern, as a resident, that's really important to provide direct care, and that's critically important for the patient, of course. But if you also want to achieve broader impact, it can be very helpful to have a broader perspective on health and disease and why people suffer when they don't have to suffer. So that's where my calling came from, Brandon. If you look at my journey, I trained in multiple areas. I think I'm the only physician in the United States who's quadruple boarded and has been chief resident twice. I got a lot of kidding, and also have a public health degree. I got a lot of kidding along the way. Oh, gee, you just like training, you like taking all these extra exams, and that was not it. I was, in hindsight, on a search. But what I'm very grateful to for public health is that this is an area that has welcomed me. It's endlessly fascinating. It's endlessly inspiring. You never know what you're going to get when you wake up in the morning. Who would have predicted COVID right now? We're approaching 1 million deaths in the country now in the US, Brandon. I mean, that's unfathomable, right? And what bothers me tremendously is that this is a fast pandemic that's come upon a slower pandemic of chronic preventable illnesses that also, and conditions that also could have been prevented. So we got a lot of work to do. And I'm just inspired by the mission of the field. So I think along the way, if you can find something that you realize is a calling for you and it gives you a sense of meaning and purpose, that's basically what it's all about.
Certainly, I recall when we did the Spiritual Lives of Leaders course with you as one of the instructors, talked a lot about how to find purpose in our profession, in our professional and personal lives. So thank you for sharing with us.
Thanks for mentioning that. I should stress now And thank you for, I forgot you were in that course, Brendan. Thank you for taking that one too. So, when you look at what spirituality means and how it's defined, there is actually an international definition that has to do with ultimate meaning and purpose and the significant and sacred. Sometimes that has to do with religion in a formal way, but oftentimes it doesn't. It's more informal and has to do with your relationships and your sense of mission in life and what you consider ultimate in terms of meaning and purpose. So in that regard, I would like to think that healthcare and public health is a very spiritual field and that our journey is a very spiritual journey. And when you connect with people that way, you connect with why they are doing what they're doing, not just what they're doing. And that makes our interpersonal interactions very, very meaningful. That's one reason why I love this field, if I can say.
And also from the Q&A, you mentioned the role of mentors in your life, and how have mentors uplifted you in your professional and our personal journey?
Ah, what a great question. Oh boy. If you can audition a lot of people for mentors and identify a couple, I mean, they can change your life. And I've had the incredible privilege of having a number of them. I mean, the most important ones, of course, were my parents. And so they were immigrants from Korea, and they sacrificed so much to come to this country and raise us kids and make sure that we tried to be prepared to help the next generation and, somehow get closer to the American dream. So they modeled for us, how if you do anything meaningful in life, you have to take a long view and sacrifice and have some meaning and purpose in what you're doing. When I was a young college student, I met the chaplain at Yale at the time, Reverend William Sloane Coffin, who I quote now so often. And he talked about the broader purpose of what we do in health. He said, for example, once that physicians should never treat patients like an uninteresting appendage to an interesting disease. I'll never forget that. And I often think about that because, in health, our patients often feel so dehumanized receiving care because healthcare providers are often too busy to focus on the broader person instead of on the specific appendage or disease. So mentors like that have made a big, big difference to me. And I think if you can find a couple and stay in touch with them through your journey, that's an incredible privilege. And then in turn, if you can serve as a mentor to others, that's the way you pay it back.
Thank you. And certainly finding mentors and also giving mentorship back. Really important message. Question that we just got here is, can you talk about what it's been like championing AANHPI issues in institutions where AANHPI is a minority? Like, how do you balance advocacy with the risk of being pigeonholed?
Great question. That's a great question. So I think you have to, first of all, understand that people will respect you for representing our community, or at least giving your own perspectives on it and sharing your own story. If you can humanize that story so that people can relate to it and find common ground with you, that is really important. In times like this, through COVID and the xenophobia, I think people are more willing to hear your concerns about the AANHPI community. I mean, I've been at this for decades, and if I can say, most of the time people don't really pay much attention. But in the last 2 years, they've paid a lot of attention. So I think having a webinar like this, Brandon, is really very timely. And then very importantly, if you want to work with people, you got to listen to what they're passionate about and support them, and listen as much as you speak. So if there's a give and take, and you collaborate with people, and you can show that you can be a reliable partner and colleague. I mean, those are partners and colleagues that you will treasure for life. And by the way, I now have the privilege of having thousands of colleagues that I love and respect so much in public health for exactly that reason. They're in it for the mission. They're great to work with, and they support you and you support them. And I think that's how public health goes forward.
Well, I just want to note here, we have so many great questions, great answers and insights from Dr. Ko. Unfortunately, not enough time for all of them. I want to end with a question that I think will be very relevant to our audience members here today, who are mostly medical students, public health students, or community advocates. What is something that we as individuals can do to help improve access to care for the underserved populations?
Yeah, so I teach a public health leadership class now every year, and often the students say, okay, I'm just a student and I don't have a whole lot of influence. What can I really do? But if you stop and think, each of us has a circle of concern. You can even draw a circle on a piece of paper, and that may be very big. And in healthcare and public health, that can be huge because we're concerned about a lot of health issues. And then inside that circle, we have a little circle of influence that's usually a lot smaller. It might be pretty tiny. Maybe, you may be able to influence only a couple other peers around you or something. But if you start with that circle of influence within that broader circle of concern and show that you can be a leader, then that circle of influence will grow. So even if you start with something very small and try to promote change for a very small group of peers or community, people will pay attention and say, oh boy, he did that well or she did that well, and they look like a good person and somebody I'd like to get to know and work with. And then your community will grow. And by the way, as I end, I just want to thank APAMSA again. I mean, I think you have 4,000 members. I mean, that's fantastic. And that obviously started in the mid-1990s with only a few people probably. And look at the growth of your organization. So that's just one example that if you start where you are, where you have some influence within your circle of concern, you can build your community, and in the long run, and with stamina, and particularly with perseverance and a sense of meaning and purpose, you can make a lot of things happen that'll make it all worthwhile when you look back.
Well, with that, Dr. Ko, thank you so much for just walking us through many of the key points in your life's journey that brought you to where you are today, that kind of the different key decision points and all the work that you've done in federal government and in state government. It's inspiring to see someone from the AANHPI background be so passionate and be able to turn that passion into policy action, public health action. As you mentioned, still a long way to go, both for the AANHPI community and for so many underserved communities across the country. But I just want to say thank you for being our representation and for fighting the good fight in state houses and legislatures, across the country. So with that, thanks, Dr. Ko. And if you want to leave us with any final notes.
Brendan, I had a wonderful time with you, and congratulations to you and Donna Tran and the whole organization, and keep up the good work. I really enjoyed this webinar, and thank you so much.
We enjoy the rest of your afternoon, and thank you to the audience for participating and submitting excellent questions. Stay in touch with APAMSA, and we look forward to seeing you at another APAMSA event.